Hi, everyone. My name's Langela. I work on the SAM Research Committee, and today it's our pleasure to have our monthly research learning series, Talk with a Biostatistician, Part 3. We're going to be talking about advanced multivariable regression. We are lucky to have our moderator, Dr. Sangil Lee, along with three very talented panelists, Drs. Harrison, Miller, and Salhi. So I'm going to let them take it away, and I will look for questions. And please make sure you're asking as we go along. I'll kind of moderate the chat for everybody. Thank you.
All right. Hi, everyone. This is Sangil Lee. I'm an emergency medicine physician at the University of Iowa. Welcome. So we have a talented panelist today, and let me actually introduce them. It's a pleasure to have three of you. So we'll start with the Dr. Nicholas Harrison. He is an assistant professor at the Indiana University, and he is a current care 2 scholar, does research in the cardiovascular emergency. So welcome, Dr. Harrison. The next, Dr. Rama Salhi. She's a health service researcher at Mass General and Brigham and Harvard Medical School. She does a health service research, and we are excited to have you. Last but not least, Dr. Joseph Miller. Dr. Miller is a researcher at a emergency care at the Henry Ford Hospital System, and he does cardiovascular and neurological emergency research. All right, so today's topic, we are actually going to talk about the regression analysis, and this is the part of the biostatics content. Let's start with a broad question. What is multivariable regression, and when would you use it? It's a very broad topic, but let's start with this question here. So let's start with Nick.
Before getting into what is multivariable regression, the easier question to answer first is what is a multivariable analysis? And I'd say a little bit later how that differs from something. If you've heard the term multivariate, that is something that's different. They get confused all the time. Multivariable means that you have an outcome that you're interested in. It's one variable, and it can be all kinds of different things. It can be a number, it can be a binary, categorical, it can be a count, all kinds of things. And then you want to know what the association of that is with at least one or more predictors. And the thing that makes it multivariable is that it's more than one predictor. So at least, so say you want to find what the association of heart failure related death is related to SGLT2 inhibitor use during a trial. You want to see how that effect is adjusted for sex, for instance. So male versus female. That would be a very, very basic multivariable analysis, looking at what the effect of the drug is adjusted for the effect of sex and vice versa. So regression is just kind of the mathematical way, the workhorse mathematical way of doing that. There's plenty of other ways to do multivariable analysis, but by and large, regression-based techniques are sort of the biostats workhorse for doing this anytime you want to adjust for something.
Right. I think the way I often think about it is that we know that if we're just looking at one or two factors in medicine that could be related to an outcome, there's always many, many things related to that outcome. If we're just looking at one univariate type analysis, we're probably missing things that are confounding what's actually happening. Like there's some famous papers published many decades ago showing that coffee was associated with different forms of cancer, such as pancreatic cancer. Well, it may be because coffee is associated. People that drank coffee in the 60s also tended to smoke cigarettes in the 60s. And so that's the real factor that led to that. So that's what we're doing. I mean, that's essentially what we're doing multivariable analysis is we're making sure that you're accounting for the smoking, or you're accounting for age, or you're accounting for sex-based differences, et cetera.
Yeah. To add on to what Nick was saying, the multivariable analysis is what we classically think of. We want to know, is a thing associated with mortality or some outcome that we're interested in? The key is to think about the outcome. And so if each person gets one outcome, then regardless of how that outcome is measured, whether it's blood pressure, so it's continuous and you're thinking of linear regression, or it's mortality, so you either die or you don't, and it's binary, each person gets one thing. If each person gets more than one thing, then you have many options. You are thinking of repeated measures, and that becomes a multivariate analysis. What's interesting, actually, I read a paper recently that did just a lit search of the ortho literature and said that greater than 90% of the time when people said multivariate, they meant multivariable, just to give you guys kind of the magnitude with which this is conflated. But at the end of the day, it all comes down to how you define your outcome and how many outcomes a person can have.
So I've been guilty of that myself way back.
We all
I've
have.
actually seen journals list it wrong, which
Yeah.
is wild to
Absolutely.
me in their instructions.
I do wonder if we're entering an age where the words are so conflated that it doesn't matter anymore. But in a purist sense, that's different.
All right. So say someone actually wants to build a model using a regression analysis. What would be the important steps? I think you mentioned about the outcome and the predictor or exposure at this point, but what else do we have to consider?
So what kind of Joe was alluding to is you have to really understand the pathway of how these things work and what is impacting them. So what I always tell my trainees and what I do in practice is I basically write it all down. Classically in quantitative methodology, this is thought of as like a directed acyclic graph. In qualitative methodology, you think of a conceptual model potentially or some sort of flow diagram. The directed, meaning you can't have a bidirectional arrow, doesn't quite work out in medicine. But at the end of the day, if you put it down on paper and you think of all of the things that can impact it and think about those relationships, then as you start to build your model, you won't miss a confounder or accidentally adjust for a mediator or, do something that you don't mean to do. So for me, step number one is write down the association that you think is happening and all of the stuff that you think could be impacting it.
I was talking to actually an epidemiologist just a few days ago, and he has this great recommendation, which I think is true, just like you're talking about, Rama, is that whenever he writes a grant, the first thing he does is creates a figure of the conceptual model that'll eventually be edited many times to really give a concise picture of what the model is to reviewers. And so, but the same thing has to go into deciding on your multivariable analysis, because if you're not considering key confounding variables that are going to put your whole analysis up to suspicion, then you're kind of wasting the time of doing it, or maybe even doing the study if it's not powered enough to capture that data.
At the end of the day, you have to know that and I did this earlier, I use the term adjust for in a kind of loose way, and we often do that. But what we really mean when we're saying we're adjusting for confounders is that you have two variables that are associated, and then you have another variable, the confounder, that's associated with both, right? There's plenty of other relationships other than confounding relationships, like Rama was alluding to. There's mediators, there's moderators, there's all of these different complex relationships from a conceptual standpoint. And if you treat a mediator like it's a confounder because you got your conceptual model wrong, or the more simple, easy, more common way that these models go wrong, you just don't think about a confounder. For the most part, when we're talking about regression techniques, from a practical standpoint, they're usually applied in observational research. That's not actually something that is like a rule. And in fact, there's a lot of data that probably would suggest that we should be doing more regression on randomized data. But the thing that is key there is when you have observational data, it is inherently subject to all kinds of confounding. But unlike a randomized trial, if you don't think about the thing that you want to adjust for, or the thing that's a confounder there, and you don't include it in your model, the model's going to be wrong, or that you want to randomize for, right? And that gets into a whole other set of issues.
Let's see. We can actually move on to the next question. So that was a broad topic on the regression, but can you give us some examples of different types of advanced multivariable regression technique and the type of data you would use them for? So we can probably start with Rama about this.
Sure. So for the most part, with one or two exceptions, your multivariable analyses are defined by the outcome. So you think about the outcome, is it continuous? Then you think of a linear regression. Is it if it's binary, you think of a logistic regression. Those are the two that we most commonly see. If you're looking at ordered count, you're thinking of a Poisson. If you have something that has maybe multiple categories, let's say the outcome is what kind of car a person bought, and like an SUV is not necessarily better than a sedan, is not necessarily better than a subcompact or whatever. I'm clearly not a car person. Then you're thinking about a multinomial logistic regression. Or if you're thinking about survival, then you're thinking about Cox proportional hazard. So those are kind of the big broad categories. The one model feature that can be combined with these that is not defined by the outcome, but is defined by the data itself, is if you think about multi-level modeling. And so this happens a lot in observational studies, when you have data from multiple different clinics or multiple different hospitals, then you have to think about so if your outcome, for example, is telemedicine use, and the telemedicine use is based on geography, which is based on broadband, which is based on whether or not a health system has telemedicine. Now, all of these these things, it's not just the person, it's the environment they live in. So you nest them in the clinic, you nest them in the hospital, you nest them in the geography so that you can account for those multi-levels. And those can sort of be combined with the models that we sort of defined based on the outcomes.
And the other really common version of that is multiple time points. So multiple measurements within the same person, kind of like if you have observations clustered within hospitals or clustered within sites, you have measurements that are clustered within person. It gets at not necessarily the effect, what we would call the fixed effects, which is sort of when you write out the model, it's variable X has this effect and variable X2 has this effect and variable X3 has this effect. It gets to how the error around those is ultimately drawn from the complex error distribution that exists there.
And an example of repeated measures might be tracking pain scores over time of patients that may have been exposed to a certain drug class in the ED, for instance, and whether the slope of their pain curve is different in the group that got Haldol versus the group that got Dilaudid or whatnot. And so there you might use a general linear modeling technique to actually analyze that data, which differs a little bit from linear regression.
And the assumption that Nick and Joe are sort of alluding to is this assumption of independence. If I am a person who tends to downplay my pain, my first score and my second score are not going to be independent of each other because they are dependent on me as a person. So if you measure those things over time, those are not independent measurements. And so that's kind of the critical thing that we think about when we think about this type of modeling.
We can move on to the next question. So this is a question that we can start with Joe. What are some ways that you can check the regression to ensure the final model is valid or appropriate?
Well, it's funny. I was just looking at a review of an article I submitted recently to one of our journals where the editor specifically asking for the model fit characteristics because we did not submit that with the original manuscript. But whenever you're using these models, all statistical software gives different model fit characteristics, which are really telling you how well does the model you're creating, does it actually fit the data that's there? And I think it's easiest to think of linear regression maybe, and maybe you guys have other examples, but in linear regression, you're essentially fitting a line through the data. And then the model fit is looking how far do the actual data points, how far are they from that line essentially? And gives you an idea of how well you're fitting the data. And so there's certain statistics that are produced in this modeling that allow you to tell whether that fit is good as other ones. And so sometimes it could be something like changing one of the variables from age as a dichotomous confounding variable versus age as a continuous variable can lead to better fit of that model. Or whether you needed to consider another interaction between different factors in your group may lead that model to fit better. And so we can look at things like AIC and other statistics that can give us a better idea of what that fit actually is. I don't know, you guys want to add to that? That's kind of a basic description.
I think when you first foray into model fit, so I guess I'll step back and say this should be used with most models. Classically, we're taught it in the context of prediction modeling rather than observational modeling, but to say you can do it in all of them. So classically, we're taught about this R squared, which is falling out of favor. It's a pretty crude test of how well your model fits the data. So an AIC or a BIC is a much better test of the model. The other thing that you think about is the residual variance and the dispersion of your variance. So if you're really good at fitting the center and really terrible at fitting all of the rest of it, may suggest to you that there's something wrong in your model. Either it needs to have some non-parametric parameter or something else that can fit the model better. And so the classic example is you see kind of U-shaped data with a line going straight through it, which that model obviously doesn't fit that data. And so that's kind of what you want to think of is looking at the data points around that slope that Joe was talking about.
So I would add to that just to take a step back for a second. And there's a whole bunch of different things, all of these different tests and different scores that we get. And some of them are for validating a model. Some are for what we would call calibrating a model, which is actually something that's slightly different. And some are for checking that the basic mathematical assumptions of the regression technique, that those are met, or at least that they're not violated. But when it comes to the question of how do you know that a model is valid, it's actually kind of a simple answer, which is that, to use a very famous quote from a biostatistician, all models are wrong, some are useful. What that means, sort of cheekily, is that a model is always a model. It is not reality. A model can be useful if it is close enough to reality. And by that, we usually mean by prediction, but like Rama said, we can kind of get into this later because I think it's actually a really important point, the difference between modeling for prediction versus modeling for explanation of data. But ultimately, if you're to see if a model is valid, you validate it. You see how it performs in a set of data that is not what you derived it validation. There are lots of different ways to do that. There's subtle differences between internal validation and external validation. When we think of validation, external is what most people think of, where you have a model that you did in one cohort, and now you're going to a completely different cohort, often at a completely different center or setting, and then you're testing and you're seeing how it does there. And there's plenty of examples of things that looked great at first and then didn't look so great the next time. There's fancy techniques for doing what we call internal validation, which you sort of do a best guess at how the model would perform in an external setting at the time you derive it the first time. There's a bunch of different ways to do that. The oldest way to do that is you split your data in half. There's a lot newer and arguably, if not more accurate, at least as accurate or more flexible ways to do that now.
Are named after 17th century terms like jackknifing and bootstrapping and
things that have no meaning in my life at all. But one thing that I've found kind of interesting, recently I've been working with a bunch of computer scientists out where Rama is, and I had a weird moment with them where I was asking, well, how do you guys evaluate if your models fit well? Because they do AI stuff, right? They're doing these big, mostly neural net type things. And they're like, well, what do you mean? And I'm like, how do you internally validate? How do you check the models fit? And they're like, well, you train and then you test it. And then if it's not good enough, you test it again. And then if it's not good enough, you test it on some more data. And then you just keep doing that until it works. So, and I find that actually kind of refreshing, because that's in some ways a more honest, whether or not that's the right way to do it or not, it's a more honest assessment of how the question of how do you know if a model is valid or not.
Yeah, it's very honest. I think that the trouble we arrive in for most emergency medicine research is that our data is often finite. And so, or it's expensive. We could get tons of data, but sometimes it's very expensive to get additional data. And so we're working with a limited number of outcomes that in turn limits our ability to do that continual validation. And so a lot of times we are trying to come up with as good a model as we can with as little as we have.
Is that a good point to talk about events?
Yes, this is a great time to talk about events. I could start with an example that maybe could get us started. One of our residents worked on a project looking at hematoma expansion for intracerebral hemorrhage. And she was particularly interested in this concept that do patients that require multiple transportations before they get to a comprehensive stroke center, do they have a higher rate of hematoma expansion? So essentially looking at binary outcome of hematoma expansion or no hematoma expansion. And so for that, we typically use like logistic regression analysis. So this could have been a linear regression too, if you look at just the number of cc's of expansion, but we decided just a binary. But so the problem she ran across, out of a data set of 360 patients with intracerebral hemorrhage, only 60 had hematoma expansion. So you're seeing an outcome of interest in only 60 subjects, which due to the power related to sample size and what you can do in these models, we're really limited to how many actual confounding variables you can put into that model. And in the end, it's a complex issue. There's a lot of things that go into whether someone's hematoma is going to expand, whether it's anticoagulation, what was the time of their initial size of their hemorrhage, et cetera. And so in the end, she could only put in approximately 3, maybe 4 variables in that model. So we elected things like age and what the patient's ICH score, which fortunately encompasses a number of things within it. How do you power how much you could put into a model based on the number of outcomes you have?
So the classic teaching is that for anything that's not linear regression, so linear regression, continuous outcome, it's like CRP. And actually, CRP is not even a good one because it's technically bounded at 0. You can have negative CRP. So I don't know.
somebody's financial status, so net income.
Anything that's not that, what we would call a generalized linear model. So binary, logistic regression, like Joe was saying, but also for Cox regression, usually also for Poisson regression or negative binomial, usually. The general teaching is that you shouldn't have more than one variable for every 10 events, where an event is in the categorical outcome, whatever the least common thing that happens. So you can't say I had 100 patients and one had an event. So I'll say that, but I'll just say that the yes is a no and the no is a yes. So it's 99 events. It doesn't work like that. You should only have one variable for every 10 events. So in Joe's example of 60 events, you're really kind of bounded to 6 under 6 variables that you can have, or 6 things you can have predicting. Now that ratio is actually very all over the place, and there's a lot less agreement on that these days. There are papers out there that are convincing that say that you only need 5 events per variable. And then there's other papers that say you probably should be getting 20 events per variable. And ultimately it is a big range, but the idea is you need to be very careful as that ratio starts going smaller and smaller to the original reason of why that's important, though. Joe, you alluded to something earlier, which is that all regression ultimately at some level is fitting a best fit line. And it's very easy, much easier to fit a best fit line through something that happens twice and is always a 1 or a 0 compared to something that is a continuous value, or say something that happens 300 times. It's really easy to say, well, this model is 100% predictive because the two people who had the event happen to be female and have ages of exactly 37 and 69. That's not really a good model though, right?
So just sort of like talk a little bit about how this happens in practice. And there are two things that we've talked about that I would just highlight sort of in summary. The first is that you really want to think about the variables that you choose. And so Joe talked about the ICH variable being sort of more comprehensive. And so you can have one variable that's playing a number of different parts. So you don't have to put every single one of those things into the model and account for all of the statistical.
Like when nachos are stuck together, it counts as
Just
one.
like when nachos are stuck together, yes.
Another very common one that you all will see will be a Charlson comorbidity index, which includes 12 different comorbidities. So you don't have to include each individual comorbidity in a model.
Right. But ultimately, your best defense against this problem, which I'm sure that Joe and his mentee also talked about, is the relationship between the outcome and your predictor, right? And so I'm speaking hypothetically, so forgive me, Joe, for talking about your work. But for example, if they had a reviewer come back and say, well, why isn't race in your model, right? You would say, well, here is my conceptual model. I have no reason to believe that race impacts somebody's bleeding risk. If what you're suggesting is that perhaps people get injured by mechanism of injury in different geographies, I've accounted for it in this way. But if you have your model theory down, then you can sort of say, here are all the reasons this actually doesn't need to be in the model and why this thing we've presented is sufficient.
I think that's incredibly important point. That's a great way of putting it, Rama. The conceptual model is king.
So is that the reason that we are not seeing that many forward or backward selection for variables?
Yeah, they're really falling out of favor because they allow people to turn their brain off and they're depending on a p-value, which I think culturally we're all getting used to the idea that p-values are garbage. And so by extension, we shouldn't rely on processes that rely on, for lack of a better word, garbage.
I was just to say, I think they fall out of the conceptual model. There's still a role for different selection processes, whether forward selection, backward selection, et cetera, for very exploratory work where you really have no idea about the relationship. And there's some overlap with machine learning with this whole topic. But yeah, I think for a lot of our analysis of hard-earned data, it's more reliant on the conceptual model.
I would say we don't necessarily want to, or I wouldn't necessarily go to the point to say that selection techniques are completely useless and you shouldn't do them. But a lot of the ways that they tend to get applied, the most common ways they get applied, like stepwise selection is incredibly common, but whether it's forwards, backwards, stepwise, what Rama was alluding to is knocking things out because the p-value is significant or not. That, for a host of different reasons that are way beyond the scope of this talk, has been shown to really make invalid models that don't validate well. They're part of the reason why I would have such strong caution against using that sort of p-value selection technique in 2024 is you don't have to. There are much better, much less biased ways to do that. Things like shrinkage-based, what we call shrinkage-based techniques, which are like lasso and ridge regression. They either are on their own or more often involve some amount of cross-validation within it as well. So you're kind of selecting variables while validating and you're penalizing some of the bias. These are things that all, from a stats experimental standpoint, have been shown to create models that on the whole end up more often being externally valid. So there are lots of ways to do selection, mixing machine learning techniques like random forest and stuff too with more regression-based techniques is something that I don't know how valid it is because honestly, people started doing it and never really studied, but that's another thing that's out there. But the old ways of doing it, I think are still common enough that people should understand that there's better options.
I understand limitations. One other thing I'll add just to sort of say the phrase for familiarity's sake is something that you'll see in exploratory work or in sociology or anthropological work is latent variable analyses. And so if you think that things are related, but you don't quite know how, then you can actually start to build your conceptual model or adapt your conceptual model based on the patterns you're seeing. And so to Nick's point, it was an excellent framing to think about models and to learn about what you're doing. But ultimately, at the end of the day, when you get to applying that, there's just better stuff that you can use.
So we can actually shift the gears a little bit. The next couple of questions are going to be a little bit of a higher level stuff, but let's start with the Rama on this one. Can you you discuss the role of qualitative or mixed methods approaches in approaching the multivariable modeling?
So I guess what I'll say is this. I think that we are getting more comfortable with the role of qualitative research. And I think the way people have sort of come to distill it, and this is, of course, not a comprehensive explanation, but the way we've come to distill it is that quantitative work kind of shows you what is happening and qualitative work shows you why or how it's happening. And so the concept of using them together becomes really powerful, right? So when you think about, for example, cardiac arrest mortality and the geographic disparities between them, you can say with quantitative data, this is the range after you sort of adjust for EMS times or defibrillation or whatever. These are the variables that sort of play into this systematic or structural difference. But at the end of the day, to understand how that's happening, you're going to get better, more granular, nuanced data if you actually like get on the ground and talk to people and talk to providers and talk to medics and talk to firefighters and talk to them about what's happening in the care they're delivering. And so ultimately they're two sides of the same coin. And I am biased. I'm a mixed methodologist. So I think it's the best one, but I think that they just play two different but really complementary roles.
So I'm going to say something, but I want Rama to jump in and maybe have a buzzer or something. Just
Can I just mute you?
Yes, you can mute me. In case I get this wrong, because honestly, she said this is her area of expertise, is mixed methods, combining the qualitative and the quantitative more so than mine. But I think with that big caveat, what I would say is we've kind of been beating around the answer to this question the whole time we've been talking here, which is that we keep saying you want to have a conceptual model, right? Well, where does that come from? So conceptual models can come from lots of places. They can come from just one person's or a couple of people's experience, the investigator's experience. And certainly as physicians, one of the strengths of physician scientists, meaning someone who is a clinician and also does research, compared to, say, someone who is doing health services research but isn't a clinician, is that the clinician has that on the ground experience, right? So you can build a conceptual model that way. But at the end of the day, that's still just one person's opinion. Using mixed methods and particularly using qualitative data is a really good way to build initial conceptual models, refine them, and then, Rama, I think the example you were given with like, you have the cardiac arrest regression model or the differences in cardiac arrest rates, and then you go, that's sort of like refining your conceptual model after the fact too. And I don't know, is that kind of fair?
Yeah, I think that's fair. I think that this is the benefit of having it and potentially putting it in your paper is that for the next person who comes along, they don't actually have to repeat the wheel. They can go, Joe put an excellent conceptual model in his paper. I'm going to take it. I may add some things based on the other work that we've done, and then I'm going to publish that again. And so then you get to not reinvent the wheel over and over again.
I would say the other part of that, other than going by one person's opinion or by doing a formal qualitative study, we kind of talked about earlier, but the other quantitative way to do, there's some advanced techniques that get into stuff that I think we have an entire other talk on for a couple months from now. But at a very basic level and from a first step level, one of the things that we do is seeing what predictors in a regression model, whether you're using a less biased selection technique or you're doing a more exploratory analysis, building a regression model for the purpose of explanation rather than prediction. And the two, you can't really totally get apart from one of them, but the thing that's kind of unique about regression models compared particularly to machine learning models, and especially advanced machine learning models, neural nets and stuff like that, is that you do get to look under the hood at how it works. So even if you don't know if the model's valid, you at least know why the model is doing what it's doing. It's never a black box. And you can leverage that to also have a sort of qualitative approach to explanation as well. Although, again, that's still an exploratory process more than anything.
In fact, I think, for instance, we put a grant in that was funded recently where the third aim was to do some machine learning models looking at, I have an interest in autonomic function. And so looking at the relationship between autonomic function and different outcomes. And the reviewers love the fact that we propose the machine learning models, but we also propose concomitantly originally doing parallel traditional statistical models so that we could look under the hood. And even if the machine learning model turned out a little bit better, we still had under the hood information to say, well, this might be the fit we see. This is what's really going on within the model. That probably is somewhat explaining the ML model too.
I have the exact opposite in the grant I'm working on right now, where I have traditional statistical techniques, but I'm also saying, oh yeah, we'll also do a neural net too and see if it works better.
Good point. So we can actually move on to our next question here. So we can start with Joe about this one. Can you discuss some limitations to advanced multivariable regression? So is there any specific example or case when you wouldn't want to use a given approach?
Well, so one potential, and Nick alluded to this earlier, but sometimes when you're analyzing randomized trial data, you may actually want to use more univariate analysis comparing the two arms of the trial with the assumption that randomization led to an unbiased selection of participants. But that doesn't always work out so nicely though. So depending on the sample size and whatnot and your pre-planned conceptual model, you may actually have to factor in some other variables. The one issue that comes up frequently, I think, is more about, are you selecting the right model based on the outcome? And then are you considering the real data structure and whether you're, like Nick said earlier, you're in the end fitting a U-shaped curve with a straight line down the middle. I think that probably happens more than we even recognize. And if you're not very careful with playing within the constraints of your data and the modeling techniques, it's easy to think you're fitting something that doesn't really fit. And I'm sure I've been guilty of that in the past. But I don't know, where else do you guys see people making mistakes with modeling or picking the wrong things?
Non-linearity, I think, is a big one. I don't think people appreciate enough what most people just think of as capital S statistics, and generally what we call frequentist statistics in particular, are 100% fundamentally focused on straight lines and Gaussian bell curves. And we do all kinds of things to get around that by taking a straight line and applying a transformation to it that makes it a log or makes it a spline, which is piecewise polynomial that kind of goes like this. But at the end of the day, it still is requiring bell curves and straight lines, even if you transform the variables. So knowing when to transform your variables, knowing the options out there, and I think just especially recognizing that the reality of most biological processes, well, not just biological processes, but social science processes, relationships between social determinants of health and outcomes, they're not linear. Most of them are not linear. And it's how close, is it close enough to linear that you can leave it be, or that you have to do something else to.
And you guys have probably heard this before, but 90% of statistics is just looking at the data. It's not doing the actual logistic regression or complex analysis. It's actually like seeing the patterns within the data and whether they do fit a binomial, what kind of curve they fit, and whether it's exponential. And that means you have to transform some of your data to really put it into the model appropriately.
The other thing, the flip side, I'll add on a couple things. So the distribution is important for nearly all what we call parametric tests, or tests that fit an underlying normal distribution. There is a non-parametric counterpart. And frankly, when in doubt, just do the other one and see if it's significantly different. And then you can explore the data more and try to figure out where that is. The other thing that I would add is RCTs are a good example. I can't think of another example, but there are examples out there where you don't necessarily need a big complex model. Doing fancy stuff for fancy stuff's sake is never going to give you a good outcome. Well, it might give you a good outcome, but you won't necessarily know how to interpret it. And I think at the end of the day, just being really deliberate about what you choose, there's nothing wrong with a logistic regression if that's the right thing for your data.
And interpretability, like that, I'm glad you raised that too, because you can always make a model more complicated by adding extra transformations. Even if you say it's a logistic model and you have 200 events and you only have 8 things in the model. I'm doing this right now with a decision instrument that I'm deriving for cirrhosis patients. We did an initial lasso-based sort of exploratory analysis to find what are the kind of variables that are coming out of this huge data set that we have. And you could get up to 16 or 17 variables out of that. But at the end of the day, you have to ask, well, why am I doing this? If I'm trying to create a risk tool that I'm going to give to a clinician, especially an ED clinician, are they going to plug in 17 variables into something? No, it's not. And I guess bringing it back around, that'd be a great place to where you go then to the qualitative method and you say, okay, how feasible is this? Can I implement this? How do you like this to the clinicians? Surprisingly, there's very little data out there I've been able to find on how big your decision instrument should be.
I read a recent paper about it, and I'm realizing now that it's because you and I were texting.
Because I asked you about it.
I mean, it's fascinating you guys bring that up. Even this morning, I had a meeting. We're part of an HLBI-funded clinical decision support tool for heart failure called Stratify, and it incorporates 17 different variables, and it has to be calculated within the EHR. There's no way a clinician's going to be able to just calculate like a heart score or a Canadian C-spine, et cetera. But the implementation becomes very difficult. So the more complex it is, really does play to challenges around implementation.
And the interesting benefit that, for example, we saw with Wells and PERC scores, when they were initially validated, obviously nobody had heard of them. And so they performed better than people's Gestalt. The more recent comparisons have, because we're just like used to looking for those things, is they now behave pretty comparably to Gestalt. And so their use can also be a teaching tool in sort of spidey sense. That
Incorporation bias, or I think there's actually a better term for that. But yeah, you start comparing.
there's definitely a term.
You change the Gestalt until you're comparing an apple to the same apple.
When you get better at
Simulation or
spotting the
something.
apple, turns out you don't need the decision tool as much.
All right, so towards the last question, but this is actually a pretty big question, so we may actually go over our time. We can start with Nick about this. So advanced methods, including machine learning, when would this be advantageous over traditional selection technique?
So, like I said, we're going to have a whole other talk on at least a subset of these kind of advanced methods, particularly what gets lumped under the name of quote unquote advanced causal inference. And that's a whole bunch of techniques that deal with the problem where, as Rama was alluding to earlier, and I was talking a little bit about, if your conceptual model is not just predictors and confounders, if you have intermediary steps, what we call mediators, meaning variable X causes variable Y, which causes variable Z, that completely violates any regression, at least any single regression. And as you start creating models within models in complex ways, you can start getting, Rama, you mentioned DAGs earlier, and you can start getting to where you have a quantitative representation of a fairly complex DAG that has multiple mediators and moderators. Probably should define those terms too, because that may not be entirely apparent. A moderator is
Hold on, Nick. I think I have a picture that would be helpful for this. You can keep talking, but I'm gonna.
She's pulling that up. If you hear the term interaction, that's a moderator. It's one variable that changes the relationship between another predictor and the outcome. And that is something that you can do in a traditional just single regression model. Problem is when you start having mediators in there, or you have moderated mediation, you have all of these kind of complex things. We did this with secondary analysis of a clinical trial we did recently. We found some kind of interesting moderated mediation of physician behaviors in Lasix administration.
Oh, bringing back my coffee and cancer analogy.
It's classic.
So there's all those sort of techniques, and that we'll get into that in a different talk. The other things, though, that I think are worth mentioning here, because they tie in directly to a lot of the things we've said, are, because they're, for lack of a better word, sexy right now, are things like machine learning models and stuff like that. And I don't bring that back into it to say, well, you should really just be doing a machine learning model for everything. In fact, I'm actually going to try and convince you, and Joe, you actually had a great example of why this is earlier. I'm going to try and convince people that maybe you should take the opposite approach, which is not everything needs a machine learning model. One of the reasons why you would use a neural net in particular compared to a regression model is that neural nets are non-parametric, isn't even the right word, because it's so much more flexible than that. You're not really bound by any of those same straight line bell curve distribution assumptions. Doesn't necessarily mean it's better, though. You can overfit a neural net just like you can anything else. But to the example I used earlier, the computer scientists, or at least the computer scientists I'm working with, their group, the solution to that is, well, you just train it and refine it, and then train it and refine it and train it and refine it. The other downside, or the big downside, is that you don't really know how it works. So when it comes up with an answer that you can't really explain or seems off, you can't really figure out how it got to that. It becomes the further any technique goes into flexibility of putting all kinds of stuff into it without having to worry about mathematical relationships, the fuzzier and less clear it is to trace back any prediction or any output from that to what went into it.
Can I add something with the sister caveat to the one you gave earlier about qualitative methods, but about machine learning for me? Certainly not my area of expertise. The thing that I think of that I've heard smarter people than me talk about as an important thing to remember about machine learning is that what it's modeling is what's happening, right? And if what's happening is bad or wrong, you don't necessarily want to model it to keep it going, right? And so the primary area of research is around health equity and emergency care. And so if you're thinking about wanting to address structural racism or structural inequities, using that data will recreate what we have have going on in society. And so there are moments where it's not necessarily the modality that's the best modality for what you're trying to do.
Yeah, you start getting into things like algorithm bias and things that can cause really pretty terrible side effects that are unanticipated. I think maybe the other, besides talking about sort of advanced approaches to causal pathways, machine learning stuff, we talked a little about advanced selection techniques. The other one we didn't really talk about as much is multivariate data, where you have more than one outcome, more than one on the side of the equation. I know that actually doesn't mean anything when I'm in Zoom land, does it? Shows up. So that can be a little harder to understand, but I'll try and do my best using the example that we did a couple of years back. We had and actually, Joe, I can't remember if you were, no, because we didn't do it at Henry Ford, but the original study was at Henry Ford, that we were doing the validation. We had these hemodynamic monitors, non-invasive, and are supposed to get you cardiac output and SVRI, systemic vascular resistance. And obviously from a physiology math standpoint, those two are highly related, right? Like mean arterial pressure equals cardiac output times systemic vascular resistance. We, for various reasons, had reason to believe that there were clusters of patients by a particular cardiac output and SVRI. And when you have issues like that, and that's your outcome, and you want to see what are the things that predict that, well, now you have two scalar variables, two numerical variables that are both changing within one another. So they have a shared distribution, and that is changing at the same time that the shared distribution of all the predictors is. And that gets a lot more complicated, but there are techniques to handle that. I would just ask your statistician. The keywords to say are MANOVA. So ANOVA with an M, which is multiple. Fermanova is what we ended up using, which is just sort of it's not just, but it's a non-parametric version of MANOVA. There's others too, but those are kind of the two big ones to talk about. And then there is multivariate regressions that don't fall technically under either of those labels, but work similarly where you have multiple outcomes. Joint modeling of survival and other data is a common one where you have your outcome is long-term survival. So a Cox outcome, and then a biomarker as well. So for heart failure patients, that might be survival and, I don't know, BNP or something like that, or survival and ejection fraction. And those are both on the same side because the two are related, and you want your predictions to take into account that they're both related and they're both changing in a predictable way with regard to not just the things causing them or the things associated with them on the predictor side, but also with regards to one another.
All right. Thank you so much for attending this seminar. And Joe, Nick, and Rama, thank you so much for sharing your expertise. It's been a very educational, and I learned quite a bit just by moderating this session.
Thank you so much for moderating.
Thanks,
Had a lot of fun.